It's so nice to be here. I first met Daniel 20 years ago when he visited my laboratory as a newly minted Ph.D., and it's wonderful to see what he has accomplished, and I'm very happy that he's made such important contributions. Okay, today I'll be talking about science and pseudoscience in psychotherapy, promise and pitfalls in evaluating claims. I'm going to move a little bit fast and might skip a few slides in the interest of covering most material in my allotted time. Let me start with a quote. Science reminds us that our intuitive beliefs about the world are often erroneous and that we require finely honed research methods to distinguish well-tested from poorly supported assertions. So today, I'm going to argue that this quote applies to psychotherapy. It's vitally important to test claims about the effectiveness of psychotherapy and specific therapies in particular. In this slide, I want to share with you that it is important, I feel, that just like in medicine, we operate from a science-based empirical approach. And psychotherapy alone, despite its proven worth, really is in competition with psychopharmacology. And it's decreased from about 16% to 10.5% in mental health settings over the last decade. So it's more important than ever that we document that psychotherapy can be effective as a standalone treatment and also in combination with medical interventions. It's a frontline treatment that's more cost-effective than medications and better able to prevent relapse for anxiety and depression. Now, the image of psychotherapy is not altogether positive in the public eye, and I've culled together some cartoons that gives you a sense of this. I'm sure you have comparable cartoons in Romania. Here the caption is, "My wife says I'm too clingy." He's grasping onto the therapist for dear life. So the Happy Meal didn't work. Do you have Happy Meals here at McDonald's? That's what this refers to. There's a naked therapist talking to a patient on the couch. "Why are you trying to make this about me?" And this is my favorite. It's a little bit subtle. "Lassie, get help." Man is drowning, and there is Lassie on the couch with a therapist getting help. And finally, lately I've been feeling so alone, the fish in the bucket says to the therapist. There are many myths and misconceptions about psychotherapy, and these are very common. And the public and even some psychologists hold myths about psychotherapy that are not supported by research. And in a number of my writings, I've addressed myths about psychotherapy. So you might ask, what are some common myths? And there are many, so I'm just going to cite a few. One is insight is necessary for success. Second, you have to be in therapy for years. Emotional catharsis is necessary. You must confront the root causes or risk symptoms substitution. And I've heard many people say CBT is not real therapy because it's not their conception of a real therapy. Now these myths, they can discourage people from consulting with therapists, and holding these and other mistaken beliefs may affect the outcome of therapy. So today there's not only a pressing need to correct myths about psychotherapy, but also I'm going to argue that it's important to educate the public and many clinical practitioners about evidence-based treatments that are available, and to contrast these methods with less scientifically supported ones that I'm going to call pseudoscientific approaches. But the real question that we're going to struggle with as psychologists and as evaluators is this question: what works best for whom? And a critical question that students of psychotherapy ask is, what is evidence-based practice? And when I think of evidence-based practice, and many others do, it is often discussed as a three-legged stool. And each leg is necessary to provide support. So what is evidence-based practice? The three legs are clinical experience, as you can see, clinical research, and patient preferences. All three are considered part of the broader picture of evidence-based practice. So just as we would, when consulting a doctor, want to consult with a doctor who is firmly grounded in the best evidence, today I'm going to contend that it is desirable for therapists to be familiar with evidence-based, empirically supported methods when possible, practical, and relevant. Now, there are certain misconceptions about evidence-based practice, and I've outlined just a few. One is it stifles new treatments. Second, it requires a cookie-cutter approach, a one-size-fits-all approach. Third, it excludes nonspecific or common factors in psychotherapy. The next one, it does not generalize to people not examined in controlled studies and neglects evidence other than randomized trials, or what you probably know as RCTs, and therapeutic changes cannot be quantified, and all treatments are equally affected. Unfortunately, many psychotherapists do not use evidence-based practices. So here are just some stats for you. 83% reported that they never or rarely used prolonged exposure for PTSD. 73% of therapists reported not using therapist-guided exposure for obsessive-compulsive disorder. 21% and 24% respectively of practitioners who treat eating disorders administer CBT and interpersonal therapy either sometimes or never. And the majority of therapists do not use empirically supported methods with clients with depression and panic attacks. And so, unfortunately, many therapists do not even know about the existence of these treatments. And if they do, they don't use it. And you might ask, what is the appeal of these non-empirically supported methods? And I've listed just several. Therapists want to help. They have a sincere desire to do so. Different treatments, whether they are empirically supported or not, give hope. There's a desire for a quick fix. And therapists are very busy. Insurance companies, in the United States anyway, and probably here, they put a lot of pressure on clinicians. So reading the literature, we're so busy, you might have a practice that's a 50-hour-a-week practice. We don't have the luxury necessarily to do a lot of reading or attend workshops. And there is a lag between treatment and evaluation. Now there seems to be a gap or some distance between scientists and practitioners, and this is often referred to, not surprisingly, as the scientist-practitioner gap. And this statement here is from a former president of the American Psychological Association that reflects this gap. And it says, psychologists do not have to apologize for their treatment, nor is there an actual need to prove their effectiveness. Now consider this statement from Healy, who wrote a book entitled Evidence-Based Psychiatry. And he says, when treatment works, the condition being treated vanishes, and we don't need randomized controlled trials to see this happening. Yes, we do need controls traveling. We do need controls, and the conditions may vanish for many reasons, and we'll go over some of these reasons that have nothing to do with the therapy. And now consider this survey of members of the APA Division 12. Basically, on a 1 to 7 scale, where 1 is strongly agree, 7 strongly disagree with the statement that controlled practice is pertinent to their research. Only 39% of eating disorder specialists listed research as a reason for selection of treatment. 60% listed clinical experiences as ground for treatment choice. And there are many statistics like this, many surveys that reflect basically this same point. So then the question becomes, can psychotherapy be evaluated? And evaluation of therapy is a challenging task, certainly, and many psychotherapies have not been evaluated. The precise number of therapies itself is very difficult to determine. In the 1980s, there were about 60 different types of therapies estimated. By the mid-1970s, more than 130 today. I'm just estimating here based on a number of sources. There may be between 600 and 700 different psychotherapies depending upon how you define psychotherapy. Now, I want to read to you a quote. It's a little bit long from a book that I have used in the past. This is the most popular selling textbook on systems of psychotherapy. And it's written by Raymond Corsini, or it's edited by Corsini and Wedding. And he defended his decision not to include evidence-based practice bearing on the efficacy of each treatment. And he stated this: we would need a taxonomy of client problems or psychological problems, a taxonomy of client personalities, a taxonomy of therapeutic techniques, a taxonomy of therapists, taxonomy of circumstances. If we did have such a system of classification, the practical problems would be insurmountable. So I conclude we don't need complex multivariate analyses and should abandon any attempt to do the crucial perfect study of psychotherapy. It simply is not possible. And in this book, there is very little mention of research and the empirical status of the different therapies across all of the models that he mentioned. But the good news is that, that we can evaluate psychotherapy. I will suggest that today. And people can be helped by therapists who differ from them in significant ways. And I'm going to just gloss over the side, but many, many people, 70%, don't have access to psychological services. 87% of uninsured kids don't receive these services. Women more than men do, but both benefit equally. I'm going to move on. We do know something about who benefits from psychotherapy, but research on psychotherapies rarely considers the adjustment and mental health of the person prior to their seeking psychotherapy. It rarely does it consider the situational context in which problems occur and people's motivation for change. Still, there are a few things we have learned anyway about who benefits from treatment. And I think an interesting finding is that the patient effects account for very little differences within a particular disorder. There's little difference as a function of sex, age, depression, medical disorders. Not surprisingly, people who are better adjusted to begin with, they do better. Some anxiety seems to motivate change. People with situational or temporary problems seem to get better, and people who have a say in the type of therapy. And I say this because really this is an understudied area of evaluation in psychotherapy. We not only want to do research and learn what treatment works for whom, but we want to know, we do want to know who benefits from treatment, in part so we can be prepared and tailor our treatments to the individual characteristics of people. How about therapist effects? Therapist differences are actually stronger predictions of outcomes than the treatments themselves. This is now pretty well documented, but the findings are still mixed, and there are differences in samples, differences in outcome measures, and statistical analysis. And these differences seem to account for less than 9% of variance in outcome. Okay, but we do know something about characteristics of effective therapists. They possess verbal fluency, warmth, acceptance, empathy. That is, not surprisingly, they are able to establish a working alliance, and we know that the working alliance accounts for roughly between 15 and 30% of the variability of outcomes in psychotherapy study. The average I saw recently was a correlation of about 0.227 in a large meta-analysis. They modulate their affect well. They focus on the other person. They provide explanation for client distress, and they have a treatment plan. Few negative communications. They get feedback from clients. They monitor the treatment throughout. They're flexible, and they communicate hope and optimism. Okay, now what about personalized therapy? Tailoring to the individuality of the patient. Now, an APA task force was conducted to look at this, and there seemed to be some link to outcome with modifying the therapy, but only based on a few points here. Reactance, in other words, the extent to which the patient kind of opposes the directives, feedback, suggestions of the therapist. Preferences for different therapies, culture, a religion, and spirituality, and expectations less. Okay, so we know something about that. But not all therapies have anywhere near an equal evidence-based. So I want to define a couple things. What is pseudoscience? It's a term that's bandied about a lot. There's no widely agreed upon definition of what is pseudoscience, but it does have certain properties that can be defined. Its beliefs in clinical practice mistakenly claimed or regarded as based on or compatible with scientific method or empirically supported findings. Of course, what is pseudoscience one day may become empirically supported the next. Non-science claims that are not empirically supported, and we can think of science and pseudoscience as lying on a spectrum. There's not a clear dividing line. I mean, some cases are very obvious that I will share with you. One property is they make strong claims with little or no evidence, and in this cartoon it says, not only does my thought beam psychotherapy cure diabetes, I think it works on my cat too. There seems to be an all-you-can-eat buffet today of pseudoscientific psychotherapies that people can choose from. In the next slide, you can see just a short list of pseudoscientific therapies on the scene. Today, neurolinguistic programming, thought field therapy, emotional freedom techniques, facilitated communication, rage reduction therapy, sensory motor integration, rebirthing, reparenting, holding therapy, primal scream therapy, feeling therapy, past lives, alien abduction therapy, future lives therapy, angel therapy, the Sedona model, Silva model, entity depossession therapy, vegetotherapy, palm therapy, psychomotor pattern, laughter therapy, sand play, calligraphy, etc. Okay, I like this one. I like angel therapy. Therapists help patients make connection with angels to treat psychological problems. Then there's the Sedona method. And the motto for this is, if you can drop a pencil, you can drop negative feelings. It's just that easy with that method. And then there's transmundo being in regression therapy. Never figured that out. This dolphin cured my anorexia. Kind of like, the truckloads of the latest craze that are entering the city limits of the psychotherapy universe. A challenge for evaluation across different therapies is, can the change be attributed to the psychotherapy administered? And very few people have talked about this, and Scott Lilienfeld and my colleagues thought about this and tried to to list some of these reasons why a therapy may appear to be effective, yet it may have little or nothing to do with the actual therapy. Well, of course, Irv Kirsch, my good friend and long-term colleague, will give a great talk on placebo effects. But there are non-specific factors which we heard about yesterday and in Dr. DiGiuseppe's talk, positive expectations that are consistent with cultural beliefs, these obvious things: empathy, alliance, affirmation, goal, elaboration, agreement on task, action, healing setting, practice new, behaviors, suggestion, part of many therapies, interpersonal learning, and therapist effects. But there are also non-specific effects and specific effects. And the specific ones basically stem from the specific schools like behavioral, CBT, psychodynamic. Now, these can account for non-trivial differences in outcomes, but not so much in all therapies, particularly in therapies like anxiety disorders and OCD. And I think we want to avoid either or thinking. Not all psychotherapies are equal for all conditions, but there typically are not great differences, if any, when we access well-established interventions with well-trained therapists. Now, what are some of these misperceptions of actual change? We talked about placebo effects. These could account, as Irv will share with you, up to 80% of the effectiveness of antidepressant medications. Wow, right? Novelty effects. People are excited about a new intervention, and 15% of patients improve between the initial phone call and the first session. You don't have to do much then. They're in therapy and they are getting better. A spontaneous remission, even without treatment, 15 to 70% of people seem to improve. That's a broad range, but that reflects this literature. Then there's the cyclical nature of many disorders. Oftentimes people come to see us when they're at their worst, but they're disorders like depression, bipolar disorder. Many disorders are of a cyclical nature, and when a person is doing better for reasons that have little or nothing to do with the therapy, we may then attribute that to the effectiveness of therapy. Then there's regression to the mean. They're coming coming in when they're at their worst, and then naturally, because of regression to the mean, they move down. Maturation, naturally occurring psychological growth. Mark Lenzenweger has done studies showing that many patients with severe borderline personality disorder will interpret over time through a process of what, for want of a better vague term, is maturation. They get better over time when you do nothing or very little. Positive events can occur outside treatment. Effort justification. People need to rationalize the time, the effort, the commitment in therapy. And they may be engaged in other healthy things like exercise, for example, yoga, meditation, initial misdiagnosis, demand characteristics. After therapy, people oftentimes rewrite the history of their disorder and therapy. So all of these can contribute and make evaluation a little bit complex. Now, of course, one of the ways that we deal with this is through randomizing people to different groups, because we're hoping that these differences will randomize out, but that's not necessarily the case, and we typically don't evaluate. So that's one of the challenges that I was referring to in my title. So there's randomization. There are pretest measures, so we know where people start. There's the blinding of observations of therapists, of raters in studies, and there are attention placebo conditions. Now, what's considered evidence-based is a moving target. as Professor David and myself noted in our book. It varies considerably among researchers, classification schemes, international organizations, and evaluative frameworks, as the slide says, generate conflicting standards and views. So the National Institute of Mental Health in the States has one definition. Division 12 of APA has a second. The American Psychiatric Association has a third, and the Cochrane reports, which many of you are probably familiar with, that has a fourth kind of set of implicit, if not explicit, standards. So none of these schemes, and this is the important point I want to make, none of these schemes consider support or lack of it for the theory or mechanism underlying therapy. Now, Dan wrote this, I believe, in the first chapter of our book on psychotherapies. What about voodoo therapy? So can people who are participating in voodoo therapy get better over time? Well, sure, given what I've spoken about, these many possibilities, including placebo effects and expectations, it's certainly possible. But they're not getting better because of the mechanisms, because of the voodoo therapy that they were exposed to. So theory can be tested independent of the treatment package. And what we tried to do in our book is encourage people to write chapters that broke out the therapies in terms not only of their efficacy or effectiveness, but also in terms of the support for the mechanisms of change that supposedly moderated treatment effects. So most of us would agree that voodoo therapy, while some people would get better, the mechanism would not be the practice of voodoo, right? So a well-supported package we talked about in terms of empirically supported RCTs and at least 2 carefully done studies by 2 different investigators or research teams. Now, you can argue with that, but that was our standard. Well-supported theory, evidence based on 1 experimental study and or a component analysis of various components of the treatment, a client-centered interaction, and our mediation moderation analyses, actual statistical analyses done in complex clinical trial. And we had a category for equivocal evidence. No data was collected, preliminary data or mixed data, supporting and non-supporting evidence. Let me say that people, I think, are too quick to say that therapies are not empirically supported when there simply have not been studies that are conducted on these therapies. It may turn out that even though studies are not available today, tomorrow, grant findings might support a study and we could classify it as empirically supported. So this is a very tentative scheme. And then there's strong contradictory evidence, not empirically supported, at least 2 carefully done studies by 2 independent investigators or research teams. So here's what it looks like. I don't know that you can see this. You can see that this categorical scheme would generate 9 different categories, right? So you'd have well-supported, equivocal, or strong contradictory evidence, both for the theory and for the mechanism. All right, so that's the scheme. Everybody got it? Questions? Okay, 3-by-3 design, as we say in introductory statistics. So we can look at disorders like major depressive disorder. And I'm not going to go through all of this just in the interest of time, but we can see that under the well-supported theory category is cognitive therapy. Category 2, theory-driven psychotherapies, is concreteness training. REBT falls nicely in there. And strong contradictory evidence, there are none, okay? And I will summarize some of this a bit later. Here's another example of bulimia. And again, CBT comes out very nicely as a well-supported therapy. And we can go to post-traumatic stress disorder, and once again, CBT comes out looking very, very good. And then there's ADHD. Let me just get this right here. So there is some evidence here for combined treatments, that is, combined medical treatments and psychotherapy treatments. But you can see that there are a variety of therapies that have been subjected to some analyses for each one of these, and it's not an insignificant number. Oh, I'm sorry. Thank you. So when we look at the category 1 treatments, we can again see that CBT comes out fairly well. So we have it coming out fairly well in panic disorder, social anxiety disorder, specific phobia, generalized anxiety disorder, sexual dysfunctions, and insomnia. It is the strongest so far, but it's not a category 2. We also need to evaluate methodology in future schemes. Very few classification schemes that I know of, none actually. Daniel, do you know of any? Really look at methodologies. So often, we don't control for pretty important factors. We don't control for coexisting conditions, medication or medication compliance, which is very important, socioeconomic status, therapist and client variables, and prior treatments. Here are some additional considerations. Very rarely do we really consider the weight of the evidence in these terms. You could say that some comparisons are strong comparisons. For example, if you have a solid placebo control condition, treatment is usual. Is it better than what therapists usually do versus a wait list? Because if you compare almost any therapy against a wait list, people will do better. So that's a pretty weak comparison condition. So we shouldn't have too much faith in a particular therapy where the conditions strongly favor that therapy when the only countervailing conditions are a wait list. Meta-analyses are very important, and meta-analyses are oftentimes presented without a risk of bias assessment. What that means is it doesn't present along with the meta-analysis things like how many subjects were there? Was it an adequate number of findings to show differences? Were the raters blind? Did they consider people as treatment failures who dropped out of treatment? So there are maybe 10 or 20 or 15 different factors by which you can begin to judge methodology, but very few studies do an adequate job of really doing this. What about internet delivery? This is turning out to be very promising, actually. It has the promise to help large numbers of people, but we don't have a lot of good data on this. With large sample sizes, we need more research. So far, we're talking about outcome research, right? But a lot happens. We're therapists, most of us. We know that a lot happens between a therapist and a patient. We don't quantify this. We don't look at this in many studies. We look at the outcome, and we assume that all things are equal between the inception of the therapy and the time that we measure the therapy. But this kind of an outcome is not justified. We need to look at process. Why aren't there more process studies? Because they're time-consuming. They require grants. People do not make careers out of 2 or 3 studies that are grant-funded. They make careers based on numbers of studies published in generally reputable journals. It's hard to get money for these studies. And they're complicated studies, and they are time-consuming studies, but they're very important. Oftentimes, we don't evaluate the size of the effect. In other words, was it a large effect? Was there a large mean difference and relatively small standard deviations? Relatively not a lot of variability, so these differences are really statistically meaningful, but are they clinically meaningful? Do people go from one diagnosis to no diagnosis? Tricky stuff. And what about personalized approaches versus non-personalized approaches? In one large meta-analysis, CBT was looked at, and there really were not many differences across measures, but CBT was somewhat greater with personalized approaches with adults, university students, comorbid addictive behaviors, and internet-based approaches. We need to look more at these kind of personal differences. Now, this is something that I haven't seen written up very much. How many of you know what Ardoch is? I'm just curious. If you have, raised your hands. Ardoch is a new approach that kind of eschews the traditional classification system. Why? Because the traditional classification system places people into certain categories, right? And either you have bipolar disorder or you don't. Ardoch has a continuum approach, but what it also does is it evaluates people on multiple dimensions. And it is designed to actually encourage research among clinicians based on dimensions that are not considered in the traditional diagnostic DSM-5 manual. Now, to get a grant in the United States, it's almost essential now that you use this Ardoch classification scheme. It doesn't necessarily preclude studying people using a DSM perspective, but you can classify people in terms of genetics, aspects of neuroscience, social interaction, big in terms of brain circuits, threat, and reward processing. So for depression, for example, there might be problems in brain circuits related to reward processing, associated with dopamine, supplemented with genetic and social information. I can see in the future that people will be using Ardoch as a classification scheme. So does the therapy affect someone's social relationships? Is it being moderated or mediated through the action of brain circuits? So there's really much to learn. There are classification systems to be developed. Then there's therapy in the real world. Evaluation of psychotherapy does not really study therapy very much in the real world. Many therapists combine techniques. In fact, if you look at how therapists define themselves, they define themselves as eclectic. They define themselves as integrative therapists. Not all therapists, but many do. So then the question is, do we want to combine different approaches? And if we do, how best do we combine, just for example, CBT with ACT? And many clients don't seek problems because, hey, I've got a diagnosis of depression and I want to see a therapist and I no longer want to have that diagnosis. The people I see, they have problems in living. They have relationship problems. They have conflicts. They have conflicts about what car to buy. Should I stay in a relationship? Should I leave the relationship? But we don't really evaluate people in terms of oftentimes what they come into therapy for. What are the practicalities? Have they dealt with that particular problem in living? We can look downstream at the depression and anxiety, but very few people in my practice just come in and say, I have crippling anxiety attacks. They talk about how do those anxiety attacks affect my social relationship. You know, how do they affect my self-esteem? How does my self-esteem affect my anxiety attacks? Whatever. We don't look at these kinds of complicated reciprocal relationships. So it would be nice if we would evaluate therapies for specific problems across specific folks, specific personalities. And there's this movement toward transdiagnostic and transtheoretical approaches. And if you're not familiar with Barlow's unified protocol for the treatment of emotional disorders, I suggest you do familiarize yourself with that, which can also be incorporated into many treatments. We just reported that working with 5 very difficult to treat patients diagnosed with dissociative identity disorder, we were able to very effectively treat these people without focusing in on this personality and that personality and how it interacted. What we did is we isolated certain variables we worked on in therapy, like emotional regulation, right? Like their tendency to hyper-associate, their avoidance responses, their self-labeling themselves as multiple personalities. And basically the scheme is something like this. Rapport building, psychoeducation, providing a rationale, working to enhance motivation and expectancies, training in awareness of emotions and sensations, a lot of emphasis on cognitive reappraisal, non-avoidance, and relapse prevention. And there's a vast literature, not vast, it's a good-sized literature showing that this particular technique is effective with many different disorders. To really, really, I think, have a wonderful control group, you would want to compare our REBT, for example, with this sort of therapy, or integrate this type of therapy into 2 different therapies. Now, I'm not saying this is the only therapy, but I think there is a movement in psychotherapy toward identifying key variables, helping people to address these key variables, and then looking at outcomes and being able to specify what are the mechanisms that are associated with change, with measures that are sensitive to these variables. So I'm going to close. Oh, I'm doing pretty good on time. Just saying, I think we've come a long way. We recognize the importance of evaluation. We've developed tentative, workable, and always improvable schemes for evaluation. We recognize the importance of evaluating theory and effectiveness. We are now aware that transdiagnostic and transtheoretical interventions are promising. There is, thankfully, an increased awareness of evidence-based therapies. We recognize that work needs to be done. So in my mind, we've come a long way, but as you can see, there are many, many important questions that still await our addressing them, and there are exciting times ahead in the field of psychotherapy and in the evaluation of psychotherapy. Thank you.